to everybody joining. I am Dr. Deva Boone from the Southwest Parathyroid Center, and today we're going to talk about parathyroid surgery. Now, I am kind of an expert in this because this is all I've done for the last 12 years. So my training was in general surgery, and then I did an endocrine surgery fellowship, and then after that I went into parathyroid surgery, and that's all I've done pretty much for the last 12 years, just parathyroid surgery. So I've done a lot of these, I've done thousands of operations. My techniques in doing the operation, my approach to the operation has evolved, as it should if that's the only thing you do for 12 years. Really, you should be getting better and better and modifying things and learning what works and what doesn't work. So I was at the Norman Center, the Norman Parathyroid Center in Tampa for 6 years, straight out of fellowship, and a lot of the techniques I use are from there, are adapted from there. And I do some things, a couple of things differently since I left in 2020. So a few things have evolved, and I'll go over that. I'll go over exactly why I do things the way I do. Whenever you have surgery, you should have a good idea of why the surgeon's doing what they're doing, and the surgeon should have no problem with answering those questions. So at the end, I kind of talk about what questions you should ask your surgeon, but really, whatever questions you want to ask, the surgeon should be able to answer that in a way that satisfies you. And one of the essential things is finding a surgeon that you like, that you trust, and that will answer your questions. That's really important. Let's get into this though. Okay, so parathyroid surgery. I have slides to kind of keep me focused here and help this along. So here we go. All right, parathyroid surgery. Obviously one of my favorite topics. Okay. So parathyroid surgery is surgery on the parathyroid glands. That's obvious. We're doing it mostly for primary hyperparathyroidism. So on other videos, you can figure out the diagnosis. Mostly what I'm going to be talking about is surgery for primary hyperparathyroidism. There are cases in which you will operate on secondary hyperparathyroidism. And then finally, tertiary hyperparathyroidism also gets surgery, but that we haven't even talked about because it's a less common disease that really occurs more in people who have had kidney transplants. But okay, so for parathyroid surgery, I'm mostly talking about people with primary hyperparathyroidism. All right, the goal, number one goal, is cure. This should be kind of obvious, I guess. I put it here actually because I want to talk about the other goal, which is to minimize harm. And both of these are equal, actually. So I don't want to get you cured at the expense of safety. Why does this matter? Because we are going to have to make some choices when doing the operation. We really want to get the operation done in a way that has the highest chance of getting you cured and the lowest chance of doing harm. And sometimes these things will be in conflict. So that's why I put them here. I'm going to come back to this. We're going to come back to this a bunch, actually. The two goals of getting you cured and minimizing harm. These should be thought of as equal goals. They are really both there. What does cure mean? Well, a cure typically means that your calcium and parathyroid hormone levels go back to normal. They don't do that immediately. Your parathyroid hormone drops immediately after surgery, but it can take a little bit for your calcium to normalize. It actually will take at least a few days, and oftentimes it can take a few weeks for everything to settle out and for us to know that you are cured. But a cure is basically getting you back to normal calcium and PTH function. That's a cure. Minimizing harm is obvious, sort of. You don't want any complications from the disease, but also you want to minimize the harm that can occur with unnecessary testing, unnecessary procedures, unnecessary anesthesia. All of those things can contribute to harm, and we want to minimize those. Okay. Now, parathyroid surgery. So a lot of times people get kind of bogged down in the details of it. So patients will ask questions like, are you using intraoperative PTH as their first question? And really, if you understand some of the more basic parts of the operation, that is not quite as essential as you might think, even as a question. So let's get back to the basics and back up a second. When you're talking about parathyroid surgery, really, you're going to divide it into two main categories. It's either going to be a four-gland operation or a focused operation, okay? Meaning, four-gland is looking at all four parathyroid glands. Focused is looking at one gland, usually, typically. This is not minimally invasive versus not minimally invasive. Every parathyroid operation now is pretty much minimally invasive. The term doesn't mean that much for parathyroid disease anymore. What it would mean or used to mean is a smaller incision. You can pretty much always do parathyroid surgery through a small incision. So everybody's going to get a 1-inch incision. If you do have a lot of extra tissue in your neck, a lot of muscle, sometimes you need a little bit bigger incision. If you've got a big thyroid, sometimes you need a bigger incision. Pretty much everybody's getting a small incision. We're not talking about a huge neck operation where it looks like you're Frankenstein. We're talking about minimally invasive. So minimally invasive is pretty much every parathyroid operation done today. The only exception would actually be scarless surgery. So there is something called a scarless parathyroidectomy, meaning you don't have a scar in your neck. It's actually much more invasive, but you don't have a scar in your neck. They go in, there's a couple ways to do it. One way is to go under the lip and they kind of tunnel down and tunnel all the way down to your neck and down to here. Another way is like through the armpit, you can go up. That's actually much more invasive. You have to do a lot more dissection with that. So that's not minimally invasive, but everything else where you're going through an incision in the neck is going to be minimally invasive. Okay, so within that, you can either look at one gland and go from there, or look at all four parathyroid glands. That's where the big decision is. That's what we're deciding initially is, are you going to look at all four? Or are you going to only look at one? All right, so for four-gland direct visualization, this is what I do, and I'll explain why. You've got four parathyroid glands. We know you've got four. Most people, when they have a problem like primary hyperparathyroidism, will have a problem with one. Sometimes they'll have a problem with two. Sometimes they'll have a problem with all four. The thing is, you may not know that until you actually operate, get in the neck. Imaging can't really show you that. A lot of times imaging is just plain wrong. And we talked about that a lot during the last time when we talked about parathyroid imaging. There's a lot of nuance there, and parathyroid imaging can be great for certain things, but it's not actually that great at finding parathyroid tumors, especially when they're not huge. So every scan will show a big parathyroid tumor, but a lot of scans, if you have a smaller parathyroid tumor, they're not going to show anything at all. And if they do show one parathyroid tumor, you don't know about the others. You can't guarantee that the other glands are okay just because they're not seen on the scan. They may still have a problem. The rate of this is fairly high. In my patients, about 70%, or a little bit under that actually, will have a single bad parathyroid gland. So 30% have more than one bad parathyroid gland. So if I only go in and didn't look at the others and only look at one gland, there is about a 30% chance that I would miss another bad parathyroid gland. So four-gland direct visualization is a great option if you can do it. Why don't all surgeons do it? So this is a common question I get is, if it's so great, why doesn't everybody do it? The answer is because it's really hard to do. If you don't do this all the time, it is hard to find parathyroid glands. Parathyroid glands are tiny. And when I show you this, it looks really easy. It's like, oh, there's the thyroid, there's my little cartoon parathyroid glands that are normal, and there's this massive thing here that's abnormal. I mean, it looks really simple to just go in, you just open up, and there they pop out. That's not how it is. It's hard to find parathyroid glands. It's hard to find normal parathyroid glands. It's hard to find parathyroid tumors sometimes. There are a lot of other tissues here that this diagram is not showing, and these glands are often hidden within there. And then you're dealing with other structures that surgeons get nervous around, like things like the nerve that controls your voice. You're right up against the esophagus and the carotid. So you're not just dealing with you know, a cartoon parathyroid tumor in a textbook. You're really having to look through a bunch of tissues that sometimes look pretty similar to parathyroid glands. Parathyroid glands are these nice little yellow-orange things that can look a lot like fat sometimes. Sometimes lymph nodes can look like them. It's not easy. It takes doing a lot of parathyroid operations, a lot of four-gland parathyroid operations to get good at finding all four glands. If you don't have a lot of experience with it, it can take a long time. And if you're going to spend 5 hours in the neck, you are doing more harm. Remember, go back to our basics, our basic two things. Get cured, but minimize harm. If you're going to spend 5 or 6 hours looking for parathyroid glands, you are potentially causing harm. Being under anesthesia for that long is not healthy, and especially if you're older, it's really not good for you. So, yeah, if you can find all four parathyroid glands quickly, then it's a great option. If you can't, and that is true for most surgeons doing this operation, then they may not be a good option for you. Yeah, and I'll talk about that more in a minute. The benefits, though, of direct visualization, it's got the highest cure rate. It has the highest cure rate because it has to. So many parathyroid tumors are small and show up on no scans that it really, you'll never be cured unless somebody actually goes in and looks at the glands. Parathyroid glands don't need to be seen on imaging. So I actually, I don't care if you have negative scans. A lot of surgeons do, and they don't want to do the operation if you have a negative scan because they then have to look at all four glands. I don't care about that. Most of my patients have negative scans. Again, that's still selection bias, right? People come to me because they have negative scans. But most of my patients have negative scans and they still get cured. So you don't need to see anything on imaging if you're going to go in and look at all four glands. You can confirm that the other glands are normal. This is a big deal because those other parathyroid glands, you're taking out a tumor, you don't really know unless you actually look at them. And I will say for a lot of these, I will biopsy normal glands. I spent some time on another video explaining why I do this. I spent about 8 minutes explaining it, so I don't know if I want to spend 8 minutes explaining it again here, but it does make sense to biopsy normal glands in most cases. You don't have to biopsy all of them. It does help to biopsy normal glands in order to confirm and document that the glands were seen, that they are in the normal locations, that you know where they are if you ever need to go back in the neck again. It's actually really important to document that because once you've had a four-gland operation, once you've had any parathyroid operation, there's scar tissue in there. It's harder to go back to that location. So biopsying is a way to confirm and prove to everyone later on, even yourself later on, that yes, that gland was right there and that's where it was found, and we've confirmed that it was seen on pathology, so it was adequately exposed. Okay, and you can also evaluate the thyroid. If you're going to look at all four parathyroid glands, you're actually exposing the thyroid as well. So if there's any nodules, anything concerning on there, you can biopsy at the same time, you can deal with it at the same time. What about the risks? Well, there is more dissection. So you are going on both sides of the neck. You're looking all around the thyroid, back and behind it. You're doing more dissection to expose all of those glands. That means that there will be more scar tissue in the neck later on. Okay. And If you're inexperienced, it has a higher complication risk, definitely. Now, parathyroid surgery, like a lot of operations, the complication rate depends on your experience level. The more that you do, the fewer complications you're going to have. So my complication rate is extremely low, but if you don't do it very much and you're going on both sides of the neck, you're putting the nerves that control your voice at risk. More dissection can mean a higher risk of bleeding. And if you are digging around looking for parathyroid glands and you spend 6 hours doing it, there is a very high chance that you will damage normal parathyroid glands, even if you don't find them. And that has a risk of hypoparathyroidism. So there are real risks, but it's especially true if you don't do this very often. And by the way, about what's called experienced, the Endocrine Surgery Society will often publish this number. They'll say you're an expert if you do 50 operations, parathyroid operations a year. That's only one a week. That's not that many. And in order to get really good at finding and evaluating normal parathyroid glands, it took about 1,000 cases, or at least 500 to 1,000, to where I was really comfortable doing it. If you're doing 50 a year, you're gonna take 20 years to get there. It's a long time. And those are the expert surgeons. The non-expert surgeons are the ones doing fewer than 50, like 10 a year or less. You can't get good at finding parathyroid glands. You can't get good at evaluating parathyroid glands doing so few operations. And you are going to have a higher complication rate. Okay, so let's move on to the next option, which is focused. Focus is going after one parathyroid gland. This is actually the most common operation for probably in the world. It's where you try to go after just that one gland that you see on scan. So this does require having a scan, and it requires a positive scan. So you have to see where it is. Okay, here's our sestamibi scan. Parathyroid tumor is pretty obvious, sitting right below that thyroid. What if I could just go in, pluck that out, and be done with it? Well, I can. That's what most surgeons are going to do. And it works a good chunk of the time. So remember, 70% of cases are going to have a single parathyroid adenoma. So 70% of the time, that'll work just fine. You'll be cured. So a lot of patients get this done and it works out, and that is great. And if that's what your surgeon is good at and can do, then this is the operation for you. There are a lot of benefits here. So benefits is there's less dissection. If you don't do this very often, you don't have to find normal parathyroid glands. You don't have to go over that. You don't have to do a lot of dissection. It's a quicker operation. The surgeon doesn't need a ton of experience because they're going to go right after what it shows on the scan. They don't need to look around at other stuff. And about 70% of patients are going to be cured just with this, which is not bad. It is bad. Okay, it is bad. I mean, it's not terrible, but it's not a great success rate, right? Yeah, most patients though will be better. So 70% will be cured completely. A higher number will be better because the larger parathyroid tumor will be removed in most cases of focused operations. So you're removing the largest tumor. Your labs may improve. I did focused operations in training. This is before my 12 years of being parathyroid surgeon. So in residency and in fellowship, I did parathyroid operations. This is about the cure rate, but the patients would look better. Their numbers would look better. They weren't quite normal, but the numbers would look better by taking out the one big parathyroid tumor. Okay, risks. Well, lower cure rate. Again, you can't get past this. Just looking at one parathyroid gland is going to have a lower cure rate. And you may need another operation in the future in order to get cured. Those are the big risks of a focused operation. Okay. But here it comes. The most common question is coming up. Just to summarize, so four-gland versus focused, this is the main distinction in what people are doing. They're either doing 4 glands or they're doing a focused operation, okay? Some questions only apply to one, and that's what we're gonna cover now. So, I just told you had a 70% cure rate, and you're saying, no, no, no. My surgeon says the cure rate's 95%, and they have a method. They use intraoperative PTH, and that gives them a higher cure rate. Okay, let's spend some time talking about intraoperative PTH because people love to ask me about this because I don't do it. And why not? Now, listen, I have done over 6,000 parathyroid operations. For 12 years, that's all I've done. I've modified what I do over that time period. If there were something that was really good at getting people cured, I would absolutely use it. Intraoperative PTH is not a special technology that only a few people can access. It's available everywhere. It's just a lab test. I don't do it, and I actually don't think anybody should do it because of the risks. There are very real risks to it, and I'm going to get to that. Okay, but what is the theory behind it? Why do people do it? So here's what it is. It's only for focused operations, okay? That's why it's used. It's used because surgeons don't want to look at all 4 parathyroid glands, or they can't. It's not what they do, right? They can go after what's seen on scan, but they don't want a cure rate of 70%. They want a higher cure rate. So here's the theory, okay? When you've got a parathyroid tumor, and say you've got 1 big parathyroid tumor and 3 totally normal parathyroid glands, right? You're going to have 1 parathyroid gland that's bigger and that is just pumping out PTH, parathyroid hormone, right? The other glands are tiny and they're actually suppressed. So they're dormant, meaning they're not making much PTH at all because they're suppressed by the high calcium as they're supposed to be. That's what's supposed to happen, okay? So you got 1 big parathyroid tumor pumping out PTH. Now PTH in the blood has a limited span of activity. It has about a half-life in textbooks of 3 to 5 minutes, all right? So it's quick. It's got 5 minutes to do its thing, and then it's cut by half, all right? So if you've got a big parathyroid tumor and I take that out, so I'm taking out the source of all that parathyroid hormone being dumped in, if I check your PTH right before I take it out, say it's 100, and then I check it 5 minutes later after I take that parathyroid tumor out, well, I told you the half-life is 3 to 5 minutes. So at 5 minutes, I should see that PTH drop by half. And at 10 minutes, it should drop by half again. 15 minutes, half again. I should just be seeing this PTH plummet. And if I see that the PTH drops by half, well, that should tell me that the other glands are dormant, that they're not making a lot of hormone. Because if I've got 2 parathyroid glands pumping out hormone and I take 1 out, I'm still going to have that other one pumping out hormone, so it's not going to drop, right? This is a great theory. It makes so much intuitive sense. It makes a ton of sense. Unfortunately, it doesn't work very well. So this is like a theory, and a lot of people use it. And in a lot of cases, it will do what it says. So you'll check the PTH, and it'll be high, and you can check it at 5 minutes. It probably is not going to drop by half, but maybe it'll drop, right? It'll drop, and then at 10 minutes, it'll drop a little more, right? It's not dropping by half, but it's dropping. And then if it gets to the normal range, you're like, woo, okay, we're done, like because we're seeing this drop. That's usually what happens. Now, when I was in residency and fellowship, and I did an endocrine surgery fellowship, right? We did focused operations with intraoperative PTH. That's what we did. Even as a fellow, I could tell it didn't quite work because we were often standing in the operating room looking at these numbers and going, well, it's dropped, but not by 50%, and this is sort of stopped dropping, and it's sort of normal range now, but not really, and it didn't seem to work. So then when I went to the Norman Parathyroid Center and learned how to look at parathyroid glands and find all 4 parathyroid glands, I immediately stopped checking intraoperative PTH. We don't do it there. I don't do it here, and we didn't do it there because it doesn't help you. It doesn't help. It's very inaccurate. And why doesn't it help? A few reasons. The reality is that PTH takes a lot longer to drop than the textbooks suggest. So that 3 to 5 minutes thing, it just doesn't work. I don't think I ever saw somebody where that textbook, 50% drop every 5 minutes actually applied. Now, in some cases it will. Again, some people are completely cured by a single focused operation, and some people will have the perfect response to PTH. But it's not reliable enough. It can take longer. And unfortunately, what most surgeons do when this is taking longer is they just keep repeating it. Now, what are you doing in the operating room? So when you're thinking, I check PTH, right? It's a blood test. So usually they either are checking in, they're grabbing it from the vein in your neck, or they have the anesthesiologist pull some blood during the operation, and then they send it to the lab. This is not like a finger prick for glucose, right? This is actually being sent to the lab, and it takes time. It's got to go to the lab, get checked, and get the result. Sometimes they'll bring a machine into the operating room, but that still takes time. In a lot of cases, it takes half an hour to get this result. Some cases would take 10 minutes. That's kind of the fastest you're going to see. Now let's add the time up here, because we're checking that PTH before we take the tumor out, then we're checking it 5 minutes after, and then 10 minutes after, and then 15 minutes after. And we're waiting another 20 minutes to get each result. And if at 5 minutes, we get the 5 minute back at 25 minutes after we've taken the tumor out, right? We get it back, it hasn't dropped. Okay, we're gonna wait for the 10-minute one. So we're gonna wait another 5 minutes, and then wait another 5 minutes. And if it hasn't dropped by that point, what they'll do is draw another PTH and wait for that result. So we're already 45 minutes out now from the time that we took out the tumor. And then what's being done during the operating room, in the operating room right now, is usually a whole lot of nothing. You are sitting under anesthesia. You're under general anesthesia for all this time waiting. And there are risks to being under anesthesia. The longer you're under, the more those risks start to add up. So I want to keep the operation short. I can find all 4 parathyroid glands faster than it would take me to get a PTH result. So there is no reason for me to let you sit under general anesthesia and wait for a lab when actually it's not even that reliable. So this is the first problem, though. It takes longer to drop than the textbooks indicate. Next problem is PTH does drop when you take out a big parathyroid tumor, regardless of what the other parathyroid glands look like. So if I take out a big parathyroid tumor and you've got a second smaller parathyroid tumor, I'm still going to see that PTH drop. It's going to drop in the normal range, may even drop in the low range. You're still not cured because you've got another parathyroid tumor, but it's not going to show that. And this accounts for maybe most of the reoperations that I do. So in a good chunk of reoperations that I do, the patient had intraoperative PTH. And it did what it was supposed to do. The surgeon removed a big parathyroid tumor, the PTH dropped, and they stopped the operation. And that sounds good until you check their labs a few weeks later and the calcium's still high and the PTH is still high. They still have parathyroid disease. So most patients who come for a reoperation actually had intraoperative PTH, and it suggested that they were cured, but they weren't. And it's because that PTH is going to drop when you take out a parathyroid tumor. The only time it doesn't drop at all is if you didn't take out anything, which you should know because, again, you didn't take out anything. You don't need a lab to tell you that. Okay. And if you do need a lab to tell you whether you took out parathyroid or not, that's a bigger problem. You don't have enough experience with this operation. So, benefits of intraoperative PTH. The main benefit is that the surgeon feels reassured in doing a focused operation. Some people will be cured with a focused operation, whether they get intraoperative PTH or not. The intraoperative PTH is mostly to reassure the surgeon, okay, the PTH dropped, I took out a bad parathyroid gland, I'm good. That's the main thing. And in some cases that's going to be true, but in a lot of cases it's not going to be true, and that's the problem. Big risk here is the patient may not be cured, even with a drop in PTH. They may not be cured. So it doesn't really guarantee that you're cured. It's a much longer time under anesthesia. These operations are longer because you have to wait for that result. And if you don't get the result you want, you check it again and you wait again. These operations would be very long. I remember from my training, and not a whole lot has changed there. So you're in the operating room for a long time. Finally, and this is actually a big danger that I haven't even addressed yet, is sometimes the PTH does take longer. And so instead of just waiting and rechecking, the surgeon actually starts to do too much. They start digging around. And if you aren't used to doing four-gland operation and looking at all four parathyroid glands, you can do more damage, actually. I would much rather deal with a reoperation in which the patient had a single parathyroid tumor removed, the surgeon quit the operation, the patient wasn't cured, and then they come to me. It's much easier than if the surgeon started to dig around and create a bunch of scar tissue and potentially damage things because they don't know what they're doing. So that is the other bad thing about PTH is, not only can it lead you to not do enough, it can lead you surgeons to do too much, to start digging around, even when the patient's cured. Sometimes the PTH just takes longer. I do check PTH levels, right? But I check them in the recovery room about 45 minutes after the operation. 45 minutes after you get to the recovery room, that's when I check a PTH. Why do I wait so long? Because that's how long it takes to really see that response, because I know that. I know that if I check it immediately getting in the recovery room, I'm still going to see people with, higher normal PTH levels. After about 45 minutes, that PTH level is in the suppressed range. Why is it suppressed? Because those remaining glands that are normal are not making a lot of hormone. So that's what I expect to see. It takes about 45 minutes to see that. It shouldn't, in theory, right? 3 to 5 minute half-life should not take 45 minutes, but it does. We experimented with this at the Norman Center, actually, with testing it at different times, and 45 minutes seemed to be about the best time. Okay, so say it does take 45 minutes, say it takes longer, surgeon could be doing too much. If it takes shorter time, then might not be doing enough. There's just not enough benefit to intraoperative PTH, and there are too many risks associated with it for me to really encourage anybody to do it. I would much rather a surgeon just do a focused operation, take out the parathyroid tumor that they see on scan, and stop. Just stop. If the patient's cured, great. If they're not, send them to an experienced parathyroid surgeon. Okay. All right, let's move on. There's nothing wrong with checking intraoperative PTH by itself. It's just that it leads doctors to do things that they wouldn't otherwise do, or make questionable decisions, or be falsely reassured. And so that's why I just can't ever really advocate for it. Okay, but what about radioguided? So radioguided parathyroidectomy is what I did at the Norman Center for everyone. I do it in a lot of patients here as well, but not everyone, and I'll explain why. So again, let's look at the getting somebody cured with minimal harm. There are times when I think that radio-guided surgery can help get people cured, and there are times when it doesn't really help at all. And like anything, there are risks. Radio-guided parathyroidectomy means extra radiation for you. So it's more radiation. If it's worth it, then that's okay. If it's not worth it, then it's just extra radiation. And that's partly why I don't do it in everybody. Okay, so radio-guided parathyroidectomy. Here's what happens with radio-guided parathyroidectomy. So I think that there's a lot of confusion around it. Let me go back to these probes. So this is the machine we use. There are probes. This is not a technology. This also is not a technology that is only for a select few. This is available in every hospital. These probes are everywhere. And the reason is that it's actually used for certain cancer operations to look at lymph nodes. So it's very common to have these machines. They're everywhere. They're in, I would say, most hospitals in the US are going to have this machine or something like it. It's a probe that measures radioactivity level from technetium or from other radioactive tracers, but we're going to use technetium. Patients have to get a sestamibi scan in order for this to work, because when you get a sestamibi scan, you're getting that dose of a radioactive tracer through the IV, and that is what is causing your parathyroid glands to be radioactive, right? They're not normally radioactive. We're not walking around with radioactive glands. They are radioactive during radioguided parathyroidectomy because they got the scan that morning, or ideally within an hour of getting the operation, they got this scan, they got that injection, the glands are radioactive. Why does it work? Well, because parathyroid tumors are going to have a higher radioactivity level than normal glands. So if I measure the radioactivity level of your normal parathyroid gland, it should be much lower than a parathyroid tumor. Now, here's the issue with it. You can only measure it outside the body, because there's a lot of scattered radiation in the neck. So if I just put the probe up to your neck and I measure, that's not going to be the parathyroid tumor that I'm measuring. I'm measuring mostly radiation from other structures like the thyroid, which also takes up technetium-99 and will be quite radioactive. So remember when I showed you the scans of the sestamibi? I showed one earlier where I showed the parathyroid tumor. The thyroid was also really bright. Why? Because it's full of technetium. It also takes up this radioactive tracer. And remember, you could also see the salivary glands. They take up a lot of radiation. And the heart, we kind of cut the image off, but the heart's actually got a lot of radiation as well. So does your bladder, because it's being released into the kidneys and in the urine. So there's a lot in your body that's going to be radioactive. If you just put the probe up to the neck, you're mostly getting radiation from the thyroid and from other structures. Point it toward the heart, you're going to get a huge amount of radiation. So you can't just use this probe like a metal detector in the neck to find the parathyroid tumor. It doesn't work like that. The way it works is that if you take out the bad parathyroid gland and you measure it on the back table, so meaning not in the body, you have to point the probe away from the body actually and put the tumor on the probe. If you do that, you're going to get a high number. You may see the problem here. If I take out a normal parathyroid gland and I put it on the probe, I'm going to get a low number. It's going to be somewhat radioactive because it does take up some radiation. Okay, what's the problem there? Well, I just took out a normal gland. I don't want to do that, right? I want to leave in the normal glands. I don't want to make you hypoparathyroid because that's worse. That would be doing harm. So remember, get you cured with minimal harm. Okay, so what can I do? I can biopsy the glands. Problem with using the probe and biopsying glands is that when you take a tiny piece of a gland, it's going to be really low on the probe. A tiny piece of a tumor is also going to be low because it's also a measure of how much tissue is there. So even a tiny piece of a tumor is not going to give you a high number. Tiny piece of normal gland is not going to give you a high number. To get accurate, you've got to take a bigger biopsy. There are cases in which you will look at a gland and it's not entirely clear whether it's perfectly normal or not. All right? So maybe it's a little bit big, maybe it's a little bit darker, maybe it's just a little bit off. To measure, what we would do is take about half the gland. We would take a biopsy that was half the gland and measure the radioactivity level. And if I got a number that, when doubled, gave me a number that I thought was too high for a normal gland, I would take out the rest of the gland. Okay? It means taking a pretty big chunk out of every gland to measure it. You don't really want to do that. The more you biopsy the glands, the more you mess with them, the higher the risk of hypoparathyroidism, which is not what we want. So I mentioned before that I do biopsy normal glands. I take tiny pieces that are so small, they're not going to measure much on the radioactive probe, whether the gland is abnormal or not. So radioguided can help in certain situations. I do it in every reoperation when you're dealing with lots of scar tissue and you may have a parathyroid remnant that's kind of tiny. You want to take it out. You want to see that confirmation on the radioactive probe. But honestly, it's more of a reassurance for the surgeon. Again, just like intraoperative PTH, kind of more of a reassurance for the surgeon. It is immediate. When you put it on the probe, you get an immediate answer, so I'm not waiting 25 minutes to get it. But it does give you kind of that immediate, oh yeah, this is a tumor, this is making a lot of hormone. it's really radioactive, great. But in most cases, if I haven't gotten this, if somebody already has a scan and I don't need another parathyroid scan, then I'm exposing them to extra radiation for pretty minimal benefit. Because in most cases, I'm going to be able to tell by looking at the gland whether or not I think it's a problem or not. And I'm going to take out the ones that are abnormal, and I'm going to measure them on the probe. The ones that are normal, well, I don't want to take them out to measure them. That would be silly. And I don't really want to take out half of them to measure them because that would be silly as well. So in most cases, it's not going to add a lot. So that's why I don't do radioguided in everyone. If someone's never had a parathyroid scan before and I get a sestamibi scan the morning of surgery, yeah, I use the probe because it's nice. It's a nice little immediate confirmation. It doesn't add much time, you know. If somebody's had scans before and they're not a reoperation, it's a straightforward case, using that probe is not really going to add much. So I have modified my practice since I came out here to not do this in everyone because I want to minimize harm. If you don't need extra radiation, then I don't want to give it to you. So remember, radioactivity is outside the body after you've removed or biopsied the gland. That's the key. There are some benefits. The surgeon does feel reassured. It is nice, especially on a reoperation where you're taking out a tiny bad remnant, you know, to get that and see, oh yes, like this is really active. This is the problem. It is reassuring when there's just a tiny tumor, but it's making a ton of hormone. It's like, okay, yeah, all right, I was right in taking this out. But again, did it change what I did? Probably not, because I already took it out. I already knew it was abnormal, right? I already took it out. But it is reassuring in some cases. Risks, okay, extra radiation, yeah. Larger biopsies that do increase the risk of hypoparathyroidism. Again, you don't have to take a big biopsy, but if you actually are going to want to get an accurate assessment of the radioactivity of the full gland, then you have to take a bigger biopsy. And then there's, like that said, that false reassurance with small biopsies. Yeah, every small biopsy, even of a tumor, is not going to show much radioactivity because it's tiny. There's not a lot of tissue there. It doesn't have a lot of technetium because it's tiny. Sestamibi scans are pretty safe. I mean, in general, that's why I do get them on everybody. But this is a matter of an extra sestamibi scan, right? So if you've never had a sestamibi scan, I think the benefits far outweigh the risks. The benefit being looking for glands outside that normal area. So looking for glands that are down in the chest or high up in the neck, that benefit is huge. That's huge. If you've already had a parathyroid scan and it already showed something, or you already had multiple imaging tests, do you need another sestamibi scan? No. I mean, no. And that's kind of part of just risk benefit, right? I mean, if there's really little benefit, then why do it if there are risks? And there's always risks to everything. Okay. Okay. So remember, I have two goals. I want to get you cured and I want to minimize harm. And everything I do as part of the operation is in regard to this. Everything. Everything that I do is calculated, right? I've spent 12 years thinking about nothing but this operation. So I should be pretty good at it by now. And if there were something, when there's new technologies, most of them are kind of cool, kind of nice, but more technology doesn't always mean that you're going to have a higher cure rate or you're going to have less risk associated with it. It doesn't mean that at all. Everything I do, though, is focused on these two goals. Okay, so I wanted to talk about questions for your surgeon, but I knew this would happen. I spent a lot more time talking about this than I currently do. I do like to try to answer the questions, but basically for questions for your surgeon, you want to ask them what they do. You want to know if they're doing focused or four-gland. You want to know what they're using, and you just want to be comfortable with them. And no matter what, your surgeon should be open about what they do. They should have no problem with answering questions. They should have a reason for what they do. They may say that they won't look at all 4 glands because it's too dangerous. Believe them. For them, it is too dangerous. They don't do this often enough to safely look at all 4 glands. And that's okay. That's okay. I can't do every parathyroid operation. Neither can the Norman Center, right? We need surgeons to do this operation who don't do 4-gland operations. That's all right. A lot of people can be safely operated on and get their big parathyroid tumor out. And if they're not cured by a focused operation, go and see somebody else. But you want your surgeon to do minimal harm in the process. Okay, so I do want to answer the questions from here, and we have fewer questions, so that's good. We can answer them quickly. Okay, so let me go back here. Okay, so in the last 10 minutes, all right. So Marta asks, post-surgery, what range should your calcium and PTH be? How do you know when your bones are replenished, if that makes sense? Okay, so hopefully they're going to go back to normal range. Now, that doesn't always happen for multiple reasons, but where I would like to see labs, I'd like to see a calcium level in the 9s, and I'd like to see a PTH level in the normal range. It's not that uncommon to actually get secondary hyperparathyroidism after parathyroid surgery because your bones have been deficient in calcium, they're taking up the calcium, and if you don't take enough calcium, then you can develop secondary. So you can have a low blood calcium and a rising PTH level. So that occurs not infrequently. But ideally, once you get that treated, you should start to see the normal levels. Now, how do you know when your bones are replenished? Well, that's a tricky question. There are ways of measuring bone turnover. There are labs you can get checked. I don't necessarily check them in everyone. You know, it's the CTX and the P1NP, and you can check those to kind of see that you see abnormalities before surgery and you see them normalize after surgery. Is it entirely necessary to check those? Not really. It's kind of more of a research thing, really. It's seeing it for the benefit of proving that yes, things are getting better. So other than that, there's no real way to know. People talk a lot about hungry bone syndrome, which is actually a very, very rare condition and very serious. And most people after surgery are not going to have it. They're going to have low calcium because the bones are taking up calcium, but they're not getting hungry bone syndrome, which is its own extremely serious. You're in the hospital for it. You're in the ICU. It's serious. Most people, what they call hungry bone is just, your bones are taking up calcium, your calcium level is a little bit low, and it's normalizing. And to know if your bones are replenished, I mean, over time, you're going to see an improvement in bone density, and you'll see improvements on these labs. Okay. Ellen asks, if a patient has painful cervical radiculopathy, how do you prevent additional pain while manipulating the neck during surgery? Okay, so this is good. This is actually not uncommon, right? A lot of people have neck issues. So what we do is we want to know about it ahead of time. So definitely let your surgeon and anesthesiologist know. A lot of the manipulation, there's not a lot of manipulation. During the operation, I'm not moving your neck. I don't want anybody else moving it either. I want it to stay still. But when you get anesthesia, typically then we'll often put a bump under the neck, and I try not to overextend it. You don't want to overextend the neck, like really crank it back. You want to keep it in a more neutral position, but you're in kind of a weird position with your shoulders. There's a bump under your shoulders, and it can be uncomfortable. If you have bad cervical spine disease, what I will do is I will position you before we give you any anesthesia. So I'll say, okay, we're going to put you in the position you're going to be for the rest of the operation. Tell me that it's okay. Tell me you're not getting symptoms. You feel okay. We're going to keep you in this exact position the entire time. So that's what we do if it's really bad, and that's what you want, because during the operation, I'm not manipulating. I'm not moving things. It's just kind of after you're intubated or you're sedated, that's when we put you in position, basically to get the neck a little bit extended. And for most people, that's fine. We're actually pretty gentle about it. we hold your head up, we support your head and your neck during that. But if you have really bad C-spine disease, and some people do, we want you to be in position, know how you're going to be positioned before you go to sleep so you can tell us, okay, this is okay. All right. Margaret asks, does having Hashimoto's and thyroid nodules complicate parathyroid surgery? Yeah, it can actually. There are a couple things, I didn't get to this, but there's a couple things that can make parathyroid surgery hard. And one of them is, a big one is Hashimoto's, or any form of thyroiditis. When the thyroid's inflamed, it's definitely a little more difficult to find the parathyroid glands. And people with Hashimoto's tend to have smaller glands and smaller tumors. So that just adds to the difficulty. It does make it more difficult. However, Hashimoto's is extremely common, so I operate on people with Hashimoto's every day. It's a condition that's out there. I have it too. So it's it's not going to stop you from having surgery, but it does make it a little bit more difficult. Now, for thyroid nodules as well, if you've got large thyroid nodules, it can be hard to get around them. The superior parathyroid gland is typically behind the thyroid, usually even up against the trachea behind the thyroid. So it's really back there. And if you've got a big thyroid, it can be hard to get around. Sometimes I'll have to take out the larger nodule just to get the thyroid, get in a position where I can even see the parathyroid glands. It doesn't prevent you from having surgery though. Okay, so Drina asks, my PTH blood work has shown the following numbers: 77, 117, 79, and 79. I'm assuming you're talking about picograms per mil. Only once were my calcium levels high. Otherwise, calcium level is now normal at 4.7. I'm not sure why my PTH continues to be a high number. I also have Hashimoto's. I'm assuming you're talking about the ionized calcium. 4.7 is a little bit on the lower end. I like to have total calcium levels because ionized calcium, it's a little bit less reliable in the outpatient setting. It's very good for ICU, but it's not great for people in the outpatient setting. So I do like to see total calcium levels. It's a little bit more reliable for people who are not in the ICU. But okay, so I have Hashimoto's, I had radiation. I currently feel like I have small adenomas right beneath my thyroid and my upper chest bone. Could any of these cause PTH issues? So we think probably radiation could contribute to parathyroid tumors, maybe. It's not a big one, especially when we get radiation now. It's pretty focused. We try not to have it extend out in a lot of areas. Could it be related? Possibly, but I'm more concerned about the labs. I mean, really, the way we diagnose this is with labs, not with, other history. We really need the labs. Calcium level is 4.7. Ionized, that sounds like it's on the lower end. Now, if you had a true high calcium level, I would be more concerned with primary, but I would need to see everything together. This gets back to the diagnosis and kind of borderline labs and looking at calcium. You really want to see the trend over time. I want to see the PTH with the calcium. If your calcium levels tend to be on the lower end with PTH levels that are higher, that suggests more secondary hyperparathyroidism. So yeah, some of these other things, it doesn't help us diagnose it or not. The Hashimoto's doesn't matter. It's unrelated. The radiation is plus minus, could it be related? Probably not. Kidneys look okay. It says you have osteoporosis and high cholesterol. Really, you need to see the calcium levels over time. Those PTH levels are a problem because they are going to contribute to osteoporosis, but you do want to get to the underlying issue. If it's primary hyperparathyroidism, that's treated with surgery. If it's secondary, that's treated with supplements or other issues, but finding the underlying cause. So really, you want to see those calcium levels and PTH levels together and get your total calcium checked. Okay. Also, another thing is you can't really feel parathyroid tumors. When you feel something in your neck, most of the time it's a lymph node. Sometimes it's the thyroid or thyroid nodules. But parathyroid tumors, even when they're huge, they tend to not be palpable. You can't actually feel them because they're kind of soft and squishy, and they're usually deeper in the neck. Okay. Okay, and Mike says, almost 2 years since my surgery. Okay, great. Getting a DEXA scan. Perfect. Hopefully we see some improvements and everything as well. Good. And Drina says you started taking more calcium or vitamin D. That may give it to you, especially if the calcium levels would be on the low range. Then it's more likely secondary hyperparathyroidism. Okay. All right. So yes, I went longer with the talk, but we were able to answer the questions. Thank you, everybody. I will post this on YouTube pretty soon. I promise. All right. But take care. And next month we'll cover a little bit more about exactly how to prepare for the operation. All right. Have a good night.